Welcome back to another Am I Mental podcast, Doctors in Court edition. My name is Dr. Sabine Fonderson. In today's episode, I'll dive into another challenging case involving a general practitioner, a diagnosis of polymyalgia rheumatica, and a patient's dissatisfaction that led to a formal complaint. This case brings up vital questions about the limits of clinical judgment, patient communication, and what happens when a doctor's treatment choices are questioned. We'll walk through the events, analyze the decisions made, and discuss recent evidence on patient care in similar cases. This is a case that's more than just a diagnosis. It touches on doctor-patient relationships, how doctors approach treatment decisions when there's room for interpretation, and the complexities of managing patient expectations. So let me set the scene. The story starts with a patient we'll call Maria. As usual, I'm using fake names to protect patients' identities, but the cases are real. The patient is called Maria, and she sees the same GP for over a decade. In late 2008, she started experiencing persistent abdominal pain. Her doctor prescribed medication to manage her stomach issues. But at a follow-up visit, he suspected polymyalgia rheumatica, and that's a condition causing muscle pain and stiffness, and it's often treated with corticosteroids. And this is where things get interesting. To confirm the diagnosis, her doctor ordered blood tests and later referred Maria to an internist. And after reviewing her case, the internist prescribed a corticosteroid called prednisolone. This was expected to relieve her symptoms, but came with potential side effects, especially for patients with gastrointestinal issues. And as Maria began treatment, she started reporting feeling nauseous, and she later fainted in the doctor's office. The GP advised her to maintain a lower dose of the medication, hoping it would manage her side effects. And despite the precaution, Maria's condition worsened, and she was hospitalized soon after. After her hospitalization, Maria filed a formal complaint against her GP. She alleged two main issues. Number one, he'd mismanaged her treatment by advising a lower dosage of prednisolone, and number two, he showed a lack of concern during her fainting episode in his office, allegedly saying, "I can't do much about this." The GP, however, defended his approach. He explained that he advised a lower dose because he was concerned about Maria's history of stomach issues. Corticosteroids like prednisolone can worsen these problems and even lead to ulcers or bleeding. He argued that he acted in her best interest, carefully balancing the need to control her symptoms with minimizing potential harm from high-dose steroids. And with regards to the fainting incident, he insisted he and his team had monitored Maria and that she'd left the clinic voluntarily before he could check on her again. This brings me to the hearing, where the court evaluated whether the GP had acted within professional standards. On the first issue, treatment management, the court found that the GP had a reasonable basis for advising a lower dose due to Maria's gastrointestinal risks. He consulted with her regularly and explained his decisions. And even though Maria later required a higher dose in the hospital, the court agreed that this didn't make his original treatment plan negligent. The GP's reasoning was deemed sound based on her specific health profile. And on the second point, his response to Maria's fainting, the court did suggest that he could have followed up more promptly. However, they didn't find sufficient grounds to issue a formal warning, considering that Maria had left before additional monitoring could be arranged. And this decision underscores the complexity of clinical judgment, especially when managing medications with high risks and benefits. A GP might adjust treatment based on individual circumstances, but it's hard to predict how every patient will respond. And this case is a reminder of how managing chronic illness can require difficult choices. Corticosteroids like prednisolone are powerful, but they can lead to severe side effects, particularly gastrointestinal issues, which is why Maria's GP chose a conservative approach. This balancing act is quite common in medicine. When a patient has coexisting conditions, like Maria's stomach issues, doctors have to decide how aggressively to treat one condition without worsening another. It's a classic example of individualized care, which can be both an art and a science. And studies support this approach. One study from the Journal of General Internal Medicine shows that personalized treatment plans, when doctors consider all of the patient's health factors, tend to improve patient outcomes, especially in complex cases. However, they also require clear communication so patients fully understand the rationale behind these choices. And that's where things may have fallen short here. Maria didn't seem to understand why her GP advised a lower dose or felt adequately reassured during her treatment. And miscommunication about medical decisions can erode trust, even when a doctor has sound reasons for their approach. A 2019 study published in BMJ Open by Pert and colleagues emphasizes the importance of person-centered care in managing chronic conditions, including complex cases like polymyalgia rheumatica. It highlights that integrated care programs guided by PCC, which is person-centered care, principles, improve health outcomes by tailoring care to individual needs and preferences. And key findings of this study include 1. Effective communication. The study underscores that clear communication about treatment goals and potential risks builds trust and helps patients make informed decisions, even when treatment plans need adjustments for safety concerns. The second key finding is multidisciplinary coordination. Integrated care involving collaboration between GPs, specialists, and other healthcare providers ensures comprehensive support for patients with chronic conditions, reducing hospitalizations and improving outcomes. And the third key findings is empowerment and involvement. Patients who actively participate in planning and managing their care report higher satisfaction and improve symptom control. This approach is particularly effective in balancing treatment risks, such as managing corticosteroids side effects in polymyalgia rheumatica. This evidence supports the GP's rationale in the case to adopt a cautious treatment approach due to the patient's gastrointestinal risks. However, it also highlights the necessity of engaging patients in their care plans and explaining decisions to ensure alignment with their expectations and reduce dissatisfaction. Also, it's really important to know that thorough explanations can bridge the gap between medical choices and the patient expectations. So when patients understand the why behind treatment adjustments, they feel more involved and are better prepared for possible outcomes, even if those outcomes aren't ideal. And finally, it's a reminder that doctors need to ensure patients understand not just the treatment plan, but also the reasoning behind each decision. This doesn't just build trust, it also reduces the risk of misinterpretations that might lead to complaints or, like I said earlier, patients being dissatisfied. So let me put these ideas into a couple of thought-provoking questions for you. First, if you were the GP in this position, would you have adjusted the medication dose to avoid potential stomach issues, or would you have prescribed the full dose, prioritizing quicker symptom relief? Well, in this case, I would support the GP. I think it's important that the GP always weighs the patient's unique health factors, and that sometimes when you adjust the course of the medication, it can lead to better outcomes. However, it requires a lot of skill in order to communicate that properly to the patient in order to avoid misunderstandings and ensure that patients feel involved in their care. The second question, how do you think doctors should approach conversations about treatment risks, especially when patients have conflicting conditions? Balancing transparency with reassurance can be challenging, but it's essential to manage complex cases like Mariah's. In all my previous podcasts and the ones to follow, I am sure that we're always going to come across how doctors and patients should communicate together. And research has always shown that patients who receive clear explanations are less likely to feel dissatisfied with treatment, even if complications arise. In my practice, I always inform patients that I'm doing this for this reason, but a complication can occur, which I cannot foresee, but I just want them to know that it can happen. And I always tell them that if they do experience complications, these are the numbers they can call. For instance, if it's out of hours, they can call the out of hours GP practice. If it's during working hours, I let them know that they can contact me by phone or they can send an e-consultation. Research has shown that communication is the key fundamental issue in a good doctor-patient relationship. The impact of communication is huge, and it shows that patients who receive clear explanations are less likely to feel dissatisfied with treatment, even if complications arise. And that's so true. And that is very true. In my practice, when I see patients with chronic diseases, and I know that whatever we're doing is probably not going to really cure them, because a chronic condition typically means that you're basically giving medication to prevent things from getting worse. One of the key things I tell them is that, look, we're going to start a medication and these are the things that I expect to happen within X amount of time. And if they don't experience the needed or the expected result within that X amount of time, they should come back. And I realize that works really well, because I'm giving, number one, the treatment time to actually work, because it differs from patient to patient. And number two, I'm setting a certain level of expectations so that they don't feel like because I've given them a treatment, within the next hour, they should feel better. Sometimes patients think that once you prescribing medication, in a very short time, they should see improvement. And that's an expectation that's not very realistic. And it's really important that I let my patients know that I expect a realistic result within a realistic time frame. For instance, if somebody has an injury and it involves soft tissue, I always tell them expect between 6 to 8 weeks of full recovery, because I know that soft tissue injuries can take up to 8 weeks. And already that gives me time to reassess their complaints when I tell them, if it does get worse, you come back. But if it's staying the same or it gets better, it's going to take you about 6 to 8 weeks. And that in itself, that kind of communication has helped me a lot in making sure that my patients understand the management plan and why we might pivot to another treatment plan if things don't improve. So building a patient understanding is key to managing complex medical relationships. Thank you again for joining my podcast and my mentor, Doctors in Court edition. And in today, I showed you just how complex medical decision-making can be, especially when patients have overlapping conditions and conflicting treatment needs. And it's a powerful reminder that while clinical judgment is essential, communication is just as crucial. When patients understand the reasons behind their treatment, it can make all the difference in how they experience their care. I hope you enjoyed this in-depth look at a real-life case that highlights the intersection of medicine, ethics, and the law. Let me know your thoughts on today's questions, and join me next time for another compelling case. Thank you.